Welcome to the other side of Lucy Letby. In episode 29, we're going to look at Baby G. And Baby G was 3 counts of attempted murder, only one of which Letby was found guilty of. Unfortunately for Baby G, she had a very, very bad start in life. She was born in May 2015 at Arrow Park Hospital. She wasn't born at the Countess of Chester Hospital, and she was extremely premature and weighed only 1 pound 2 ounces. And she suffered bleeding on her lungs and had 9 blood transfusions and a number of septic or suspected septic episodes requiring antibiotics. But again, according to these people, she improved and was transferred to the Countess of Chester Hospital neonatal unit in August and was clinically stable, being fed express breast milk. We get the incidents on what they call the incidents on the night in September. Baby G was in nursery 2 with a designated nurse, not Letby. There were 7 babies in the unit with 5 nursing staff. Letby's assigned baby that night was in nursery room 1. It was a milestone night for Baby G, and nurses marked the occasion with a small celebration. Baby G was being fed every 3 hours, alternatively by bottle and nasogastric tube. Again, we have to get the drama into this. It was a milestone night. At 2 a.m., a feed had showing minimal aspirated or partially digested milk. The nurse took her scheduled 1-hour break. Nothing is recorded on who was asked to keep an eye on Baby G, Mr. Johnson said. At 2:15 a.m., the shift leader said she was sitting with Lizzie Letby when she heard Baby G vomiting, along with Baby G's monitor alarm going off. They ran into the nursery. Baby G had vomited violently and suffered a collapse. The prosecution said medical records suggest the shift leader nurse's memory of being with Lucy Letby for a period of time before this event cannot be accurate. The only person to whom medical records go against is Lucy Letby. The fact that Dr. J. Ram didn't bother writing down his fantastical rash theory in the case of Baby A and also at the coroner's report for Baby A. Nothing wrong with that, but this shift leader, her memory has got to be inaccurate. And the prosecutor says, despite Baby G's stomach being pretty much empty, well, I don't know how the prosecutor knows that Baby G's stomach was pretty much empty. Prior to her feed, 45 mils of milk were aspirated from her NG tube. Well, a baby can have a feed and not digest it. That 45 mils could be lying there, and then you would have added to it gastric secretions and intestinal secretions that are supposed to be trying to digest it. The prosecutor is talking bollocks in regards to knowing what the contents of an NG tube should be. But the prosecution said 45 mils of milk had been administered for her feed, which then did not explain what accounted for the vomit. Subsequent x-rays showed air in the abdomen and intestines. Well, there's your explanation for a vomit, but basically, preterm baby, no matter how well they're doing or how long they've been born, are subject to vomiting for no reason. We don't need to look for a reason for a vomit. And then Baby G suffered further deterioration. During intubation, a doctor noticed blood-stained fluid from the trachea, something the prosecution said was consistent with the other collapses in the case before. Here we go again with storytelling. We know that the baby is just back from Arrow Park Hospital, a proper hospital, and within a short time of being back, the baby's back being ventilated again with intubation. You go to intubate a baby and you can't see blood coming up the trachea. There's nothing to see here. At 6:05 a.m., following a further desaturation, 100 mils of air was aspirated from the NG tube. When the tube was removed, the registrar noted thick secretions in her mouth and a blood clot at the end of her breathing tube. She's got a clot at the end of an endotracheal tube. Happens all the time. There were also signs of infection. The baby had become infected as soon as it went back to the Countess Chester Hospital. The baby was transferred back to Arrow Park before returning to the Countess neonatal unit just over a week later. And during that time, baby G recovered remarkably. Yeah, because she was in a proper hospital. 5 days after her return to the Countess, baby G was due to receive her immunisations. Such was her improved condition. A team of nurses came on the shift that day, Lucy Letby being among them. Letby was baby G's designated nurse that day. Baby G was fed with 40 mils via a nasogastric tube by Letby at 9:15 a.m. And around about an hour later, baby G had a projectile vomit twice and went apneic for several seconds. Baby G's blood saturations fell to 30%. Same problem she had faced 2 weeks prior. A nurse took over the care from Letby at 11:30 a.m. as Letby was looking after 2 other children in room 4. The nurse took all the observations and noted baby G was connected to a Masimo monitor, which measures oxygen saturations and heart rate levels. It is a device which stays on and cannot be turned off by a baby. At 3:30 p.m, a consultant doctor was called to cannulate baby G. Privacy screens were erected and baby G was on a trolley with the monitor still attached. The nurse went to care for another baby. The consultant doctor said he could not recall if baby G's monitor equipment was switched off during the cannula fitting, but it is his practice to transfer the sensor from one limb to another, or if temporary attachment is required, to reattach the monitor as soon as possible. He added if baby G was not stable, he would not have left her. This is in the evidence here now. After the doctors had gone, the nurse responded to Lucy Letby's shout for help. When she attended, baby G's monitor had been switched off. The power was off, and baby G was struggling to breathe. Letby was giving ventilation breaths, and baby G responded to the treatment. In a text sent by Letby to a colleague, she wrote, "Baby G looked rubbish when I took over this morning, and she vomited at 9 and I got her screened. Mum said she hadn't been herself for a couple of days." But the prosecution said baby G had been due to have her immunisations, something which would not have been completed if baby G was not well. And if I had a quid for every time a kid was vaccinated when they weren't well, I'd buy myself a holiday home in Portugal. The prosecution says baby G had vomited because she'd been given excessive milk in her. Absolute and utter rubbish. A subsequent MRI scan revealed neurological changes, and in August 2016 it was revealed baby G had suffered irreversible brain damage. Baby G was 23 weeks gestation. She had the multiple blood transfusions, infections, and bleeding into her lungs. You basically can't get bleeding into your lungs without getting bleeding into your brain. And then Johnson goes on to say, the overfeeding doesn't happen by accident. Well, it can happen by accident if the records are not kept right. He added, similar cases will be heard with other babies. Mr. Johnson, someone had switched off the monitor when baby G collapsed, and she was discovered by Lucy Letby. That's the most interesting part of this. As I say, baby G was extremely premature and she was on the margins of viability. That's the ethical dilemma of, do you resuscitate babies of 22 or 23 weeks because the outcomes are poor? And these are really difficult decisions that I don't think there's a solution for. It's one of the human dilemmas that we have to put up with. And just Reminded again in the so-called agreed facts, the baby was born in May, Arrow Park, gestation age 23 weeks. She weighed 535 grams. That's just impossibly small. Previously, the court heard that she was the most premature baby of all the babies in the trial and the most premature baby of all babies alive in the world. She said she was in a poor condition at birth, requiring ventilation. She was cared for at Arrow Park Hospital, a tertiary centre, after being transferred to the Countess of Chester Hospital on August the 13th. At that stage, she would have been gestational age of 34 weeks. She spent nearly 10 weeks in Arrow Park Hospital, suffering all those complications. On August the 14th, that's the day after she came back, nursing notes for baby G on Friday, August 14th, recorded by Caroline Bennon, noted that currently baby G is on CPAP, positive end expiratory pressure, of 4 in 29 to 40% oxygen. 10 weeks later, this baby is still requiring 25 to 40% oxygen by positive pressure ventilation at 4 centimetres of water, and has been since the 17th of July 2015, and has occasional desaturations. Baby G is trailing off CPAP and ambient oxygen and manages 1 to 2 hours daily and may be eligible for a trial of Optiflow. Fluids are all enteral feeds. There's no lines in the baby. The baby's fed through an NG tube or by bottle. Mum intends to breastfeed and is expressing well. Full immunisations have been given on August 1st. Baby G has had a metabolic bone disease but is not currently treated. Mum and Dad have been shown around the unit and have been given a contact number. We can add a metabolic bone disease, but we don't know what that is, to baby G. And the court hears from August 14th to September 6th, baby G was treated at the Countess of Chester Hospital. And nothing is mentioned about 14th to the 6th. But on the 6th of September, baby G was 99 days old, and a feeding chart showed she had been given express breast milk and Gaviscon and the Fortif. The court is also showing a range of medications that were administered by Lucy Letby and another nurse during the night to baby G before the handover. For the day shift after the handover, 7:30, the designated nurse for baby G recorded early observations and was a co-signer for some of baby G's medications. At 11 a.m, consultant Dr. Stephen Breary records observations in an 11 a.m. clinical note. He has noted that baby G's weight had increased by this point to 1.985 kilos. That's 10 weeks old. Black note of 3:35 p.m. records all safety equipment present and correct. Further prescribed medication is administered throughout the day. 6:44, baby has another bottle and the bottles are open. 7:30, handover takes place. A different nurse to Lucy Letby, who cannot be named for reporting restrictions, was the nurse for baby G that night. Letby was the designated nurse for baby in room 1. The other nurse was the designated nurse for baby G in room 2, and another baby in a room whose location is unconfirmed by the chart. Very well recorded, organised unit that they don't even know where the babies are. There were a total of 7 babies in the neonatal unit being looked after by a total of 5 nurses. Lucy Letby was the co-signer for medication prescribed for baby G, along with the designated nurse. And an observation chart for August 6th, I think this is a typo and meant to be September 6th, shows baby G's observations are made every 3 hours and our heart rate is in the normal range at this stage. At 8:30 p.m, Letby had messaged colleague Kate Bissell inquiring about breast milk for the baby. She was the designated nurse for that night. The matter is clarified in the text conversation. On the 7th of September at 1:46 a.m, further medication is administered to baby G. signed by the designated nurse, Alicia Simpson. At 2 a.m., the designated nurse records observations for baby G. This is baby G's 100th day since birth. She received 45 mils of milk via the nasogastric tube with a pH of 4. Aspirates recorded. That's acidic aspirates, which you would expect to get from a stomach. Baby G was noted to be asleep at this stage. The milk was expressed milk plus fortifier plus Gaviscon. Lucy Letby writes a note written in retrospect at 8:57 a.m. where care of baby G was transferred to her following an event. The note says, written in retrospect for care given from 2 a.m. to present, baby G had large projectile milky vomit at 2:15 a.m. Continued to vomit plus 45 mils of milk obtained from NG tube with air. Abdomen noted to be distended and discovered. Colour improved a few minutes after aspirating the tube. Remained distended but soft. The registrar at Ventris asked to review. To go nil by mouth with IV fluids. Doctor called to theatre. The designated nurse from the start of the shift records a note. Nurse Letby taken over care of baby G following vomit and apneic episode after the 2 a.m. feed. At 2:35 a.m., Dr. Ventris' clinical notes are written at 4:40 a.m. and she was called to see baby G urgently. She had a large projectile vomit reaching the chair next to the cot plus the canopy. The abdomen appeared discoloured and distended. Baby G distressed and uncomfortable, red in the face and purple all over. Oxygen to 1 litre via the nasal cannula. At 3 a.m. she notes that baby G's bowels opened with large green watery stool. Letby adds a note. At approximately 3:15, baby G had a profound saturation to 20%, marked colour loss with apnea, bradycardia to 50, neopuff with 100% oxygen. Observation improved, but baby G remained apneic. Doctors arrived, intermittently breathing and apneic. Decision made to intubate. Moved to nursery 1. We have to remember that Letby wasn't present again in any of this. She was asked to take over. And we see that the attending physician was called to theatre. And so the baby is massively desaturating, but we know that this baby has profound brain damage and that it's only 100 days old. Every time it seems to go from Arrow Park and come back to the Countess of Chester Hospital, it deteriorates because the place is filthy and this baby is still incredibly vulnerable. At 3:30 a.m., Dr. Beery noted, called at 3:30 a.m., large vomit and loose watery stool earlier, followed by desaturation of bradycardia. Intubated by Dr. Ventris on my arrival. A small amount of blood visible on intubation. Blood samples taken and sent. Good blood gas post-intubation. Baby G's parents were notified by the former designated nurse. Blood sample for baby G was taken at 4 a.m. Lucy Letby records observations of fluid balance chart and intensive chart card for baby G at 4 a.m. The observations have gone, the court hears, from every 3 hours to every 1 hour. A blood gas record is shown for baby G from August 14th to September 2nd, 7th. Lucy Letby has signed for the last of those records. Again, what? An X-ray of baby G is taken at 4:49. Consultant radiologist Dr. Amir Rahman records for the abdomen slightly distended bowel loops, but gas noted in rectum, no transition point, mural or free gas detected on balance. At 5:15 a.m., Letby and Alicia Simpson are co-signers for medication for baby G, and at 5:30, a neonatal infusion prescription is started. 5:30 again, Dr. Alison Pentress notes approximately 5:30 had another profound desaturation down to 80 and SATs to 40%, taken off the ventilator and the IPPV Neopuff ETT. The baby is on a ventilator and has profoundly desaturated. They've taken her off the ventilator and are now using a Neopuff via an endotracheal tube. Recovered slowly, but desaturations went back on the ventilator. Ventilator problem, flow sensor changed. Then the whole ventilator changed. Dr. Berry also requires Dr. Vedras change the ET tube with less leak. They've changed the sensor on the ventilator. Now they've changed the ventilator itself. And now they've changed the tube with less leak, which means that there must have been a measurement for a tube showing a significant leak before they changed it. This is 2 intubations in the one night. Baby G had further bradycardias and poor perfusion, of course. She did. Baby G was sedated and will need discussion with Arrow Park. The parents were kept informed. Then we get 6:05 a.m. Dr. Ventus notes profound desaturation to 40%, heart rate down, decision to re-intubate. Take the tube out, put the tube back in. Intermittent positive pressure ventilation given via the ET tube. Initial heart rate 120, but SATs remained at 50, despite increase in oxygen. The ET tube was removed at 6:10 a.m. Thick secretions in the mouth, blood clot at the end of the ETT, and the face mask is put back on again. NG aspirated. His abdomen appeared very large with 100 mils aspirated. Well, where did that 100 mils come from? It came from the leaky ET endotracheal tube, the positive pressure ventilation. We don't know what the pressure readings were, but this is just calamitous. Intubating, re-intubating, masked without ETTs, masked with ETTs. And then she says, capnograph positive. I don't know what she means by that. The capnograph is the piece of equipment that will measure the carbon dioxide coming out at the end of the expiration of the baby. I don't know what that means. The plan was to continue a series of medications plus morphine. Then she talks about the re-intubation at 6:15, and there was clear air entry and bilateral chest movements. Both sides of the chest were moving, and she could hear air, but you can't gauge how much air is going in with that. Blood gases are charted, don't know what they are. 10% glucose commenced, morphine running, BBG agitated and fighting ventilator, medication given. Dr. Raymond says a further X-ray report at 6:36, comparing observations with the previous X-ray. Amongst his observations, he notes lungs have slightly improved appearances, probably reflecting improved inspiration. Again, goes to Arrow Park, does really well, comes back to the Countess Chest Hospital and has a night like this. For the night, Baby G was being nursed in a canna bed with monitoring. Feeds 180 mils per kilogram, 3/8 express breast milk with fortifier, Gaviscon via alternative bottle, and nasogastric tube. Then we just get more of these desaturations, and it just goes on and on. And then they discuss it with Arrow Park, and they're just struggling all night to establish ventilation, to clear out the chest, to control the CPAP belly. That's what it seems to me. Then at 3:30 p.m. the following day, a long line is inserted into Baby G. And Dr. Ravi Jairam, clinical note, spoke with consultant neonatologist at Arrow, agrees current management plan. Baby G's observations were noted with cool hands and feet, abdomen distended but soft. Blood gases had raised metabolic acidosis. 4 o'clock, doctor notes, Baby G required a second long line. I don't know whether that's because the first one went or they just decided to put 2 in. And baby G remained unwell, which is putting it lightly. The day shift designated nurse notes include during the morning handover 2 episodes of neopuff, ventilation increased, blood pressure deteriorated, cannula site became white, moved to another cannula. There we have another failed cannula that's just gone in. BP again improved. Doctors trying to obtain long line for better access. Same old story. Chest clear, blood gases continue to be metabolic acidosis. We have long periods of metabolic acidosis here. Minimal urine output all day. The family communication said parents on unit throughout the day and updated where the blood pressure is too low and IV access difficult. Understandably very upset and struggling to see her this poorly again. September 7, 9:45 p.m. A consultant paediatrician said at 9:45 p.m. Arrow Park were happy to accept the baby. The ambulance team is booked for 11:43. Nurse Belinda Simcock records at 11:35. Long lines, morphine administered and antibiotics. Infant to be transferred. 8th of September, 12 a.m. The transfer team arrives and the consultant paediatrician clinical record, BBG still very sick. The court hears despite a series of medications throughout the day. At 1 a.m. more observations are made for BBG. On September 8th, the transfer team noted BBG's abdomen was full and veiny. Then we have between the 8th and 16th of September, BBG was treated at Arrow Park Hospital before return to the Countess of Chester Hospital. After BBG fell ill, she was transferred to Arrow Park, where she recovered over a number of days. And on the 16th of September, she was transferred back to the Countess of Chester Hospital. And we know what's going to happen when she's transferred back to the Countess of Chester Hospital. She's going to have another collapse. 5 days later, when BBG was originally due to be born, this was the expected birth date for BBG, Letby recorded that she gave her a feed of breast milk through the nasogastric tube. The infant was asleep at the time at about 9 a.m. and was due to receive immunisations later that day. At 10:15, she went on to note there was 2 large projectile vomits before BBG stopped breathing. Her oxygen levels plummeted and she lost colour. Remember, this is 5 days later, 5 days after coming back well from Arrow Park for the second rescue. What we have to understand about BBG is BBG was such a very ill child, would have been subject to a lot of complications throughout her life. And I believe, sadly, she still is. But it seems to me that every time she left the Countess of Chester Hospital, she did well. And every time she came back, she did badly. And she didn't do badly just on the nights that Lucy Letby there. She did badly progressively over the time she remained in this filthy place. I think for the first 2 counts, Lucy Letby was not found guilty, but she was found guilty on the 3rd count.
BBG is so complicated in terms of how it's reported and the multiple charges all thrown into one, 3 attempted murders. I think it's just easier to finish BBG with a lot of questions rather than a lot of answers and a lot of things that perhaps should have been gone into in more detail. Projectile vomiting. So this is one of the issues that keeps coming up. And it's presented as a mystery. And so the answer to the mystery is that Lucy Letby injected air into the baby. But there's a major problem that no one has taken into account here. They haven't mentioned it at all. And that's the use of Gaviscon. So I think most people know that Gaviscon is used as an antacid. And in these little preterm babies, it's often given to reduce esophageal reflux. So that's where the stomach is shooting the contents back up the esophagus rather than down. And that would be a motility disorder that would be common in preterm neonates. But what happens in many people who get Gaviscon, the preterm neonates that get Gaviscon, is they create this thing called a Gavisconoma or a bezoar. Bezoar is a very old Persian word. It somehow made its way into modern medicine. A bezoar in ancient times was an antidote that people were made to eat to counteract the poison. So whatever they ate would soak up this poison, and it's made its way through into modern medicine. So the term bezoar historically refers to a mass of indigestible material that accumulates in the gastrointestinal tract. And it's often composed of substances like hair or plant material and foreign bodies and the like. In the context of Gaviscon, but the Gaviscon bezoar or the Gavisconoma refers to a specific type of bezoar that forms when Gaviscon reacts with milk proteins to create a solid mass in the stomach. And the condition is very similar to what would happen with these traditional bezoars. So these bodies, these bezoars that are present or potentially present in preterm neonates can cause obstruction of the intestine. Now, they often do that within a couple of days of beginning to use Gaviscon, but they can do it at any time during the use of Gaviscon. So the timing of it is very variable, but basically there would be a degree of obstruction to the gut. And that's all that's required to produce a so-called projectile vomit. I can't find much evidence of people who witness the projectile vomit, and there's descriptions of it being on the chair, being on the floor. So there had to be a great deal of force to generate that amount of vomiting. And only contracting against an obstruction could cause that force. And the second thing that would have made that projectile vomit possible is also the presence of a lot of pressure in the abdomen from the CPAP, the positive airway pressure that baby G was on. So if you imagine you've got this obstruction, and then you've got a lot of gas there that's pushing out, and a vomit goes, well, you've got kind of a bit of rocket fuel behind that. It's as good an explanation of why a preterm neonate would develop a projectile vomit, because projectile vomiting is usually associated with a condition called pyloric stenosis, which some babies develop, and the outlet to the stomach is blocked, and they nearly, in every case, they need an operation to relieve it. And projectile vomiting would be the pathognomic sign that you would see in that. So I think the Gaviscon, the endless use of Gaviscon on this baby is a perfectly reasonable explanation for why one or two episodes of vomiting took place. But I think it's so important to notice that every time the baby comes back from the level 3 unit, this filthy hospital, the baby gets sick within weeks, and she deteriorates. And there's references throughout this from the mother, from other nurses, of how the baby looked poorly in the days before she had the so-called final collapse. So then we get Ben Myers, who's questioning Dr. Ventus, one of the junior doctors in the hospital, and she says that the baby has chronic lung disease. So chronic lung disease, chronic pulmonary dysplasia, is what happens to these little babies when they've had so much oxygen, so many infections, and the lungs are just really damaged. You usually start with respiratory distress syndrome and then build on to this chronic lung disease. But the chronic lung disease is there now permanently. And these are very difficult babies to manage, particularly when it comes to ventilation. And we see in Dr. Ventress evidence that on the night of September 7th, at 2:34 a.m., she was called after the baby vomited and desaturated, and she decided to put the baby on a ventilator. So we have this bizarre situation where the baby goes on a ventilator, then it comes off a ventilator, then it goes back on the ventilator. They change the sensors on the ventilator, then they change the ventilator itself, and nothing seems to be making any difference. But they say in their evidence that the capnograph is positive. So if we assume from that the capnograph positive means that they're detecting carbon dioxide on the way out, then that means that there has to be oxygen being exchanged on the way in. It's the same mechanism. The alveoli, the small airways, are the ones that are exchanging the oxygen in and exchanging the carbon dioxide out. So what would be the things that would throw all this off in a baby like this? Well, there may not be enough oxygen going in, so you can still get the low oxygen saturation despite the ventilation and the capnograph looking like it's okay. But the most likely cause, in my opinion, is a thing called ventilation perfusion mismatch. So that's a mismatch between the ventilation, that's the gases going in and out of the lungs, and the perfusion, which is the take-up and release of these gases by the pulmonary bed, the blood vessels in the lung. And these diseases, CPD is what's called a heterogeneous disease, so it's not the same in every part of the lung. So the lung is going to have parts of it that are normal, parts of it that are not normal, all mixed up, very unpredictable. So in some areas, the lungs will be well ventilated, but they could also be poorly perfused, so that the blood vessels going to these well ventilated parts of the lung may not have a good blood supply going to them. And others can be poorly ventilated, not getting the gas exchange, but can be well perfused. And that can lead then to the low oxygen saturation despite the adequate carbon dioxide removal. And then, of course, there are cardiac issues that can arise out of that. And then there's all the technical issues with the pulse oximetry placement and trying to get accurate readings, not using an arterial central line, all those things that we've talked about before. And we have to consider that it's different for a preterm neonate. So what's called the tidal volume in a preterm neonate is much smaller compared to, say, even a term infant. And that can lead to the dilution of carbon dioxide in what's known as the dead space. So the tidal volume is the volume of air breathed in, inspired, and breathed out with each passive breath. That's called the tidal volume. And in an adult, for instance, it would be typically 500 mils per breath at rest. So that's 7 mils per kilogram of body weight. That's the kind of rough estimate. And neonatal tidal volumes are 4 to 6 mils, so they're lower. And the dead space is divided into 3 parts. So we have what's called the anatomical dead space, which is the parts of the lung that will transmit the gases, but they don't take part in the exchange of the gases. And then you have the alveolar dead space. That's the volume of air in these little airways that are ventilated but not perfused. In other words, that the blood vessels are not taking away the oxygen that they're delivering. That's the alveolar dead space. And then when you add them both together, you get what's called the physiological dead space. And an anatomical dead space is typically 2 mils per kilogram of the body. And so about a third, roughly, of each breath is not taking part in gas exchange. But this is going to be much worse in a preterm neonate. And that's going to mean, in the end, that you're going to get exaggerated readings on all of these machines. The carbon dioxide measured by the capnograph is not necessarily going to be represented by the carbon dioxide present in the actual arterial system. And that's because of this mismatch where the anatomy of these babies is so messed up that the blood isn't in the lungs, is not reaching the parts it needs to be. So it will measure the CO2 presence, but it can lead to inaccurate estimations of the actual carbon dioxide in the blood. And in order to sort all that out, you have to understand the very complex acid-base status. That's the acid and the base, the opposite of acid in chemical terms. Alkaline, the acid-alkaline status in these preterm babies, which is very complicated. And the ventilator settings can even affect that acid-base balance because it's going to alter CO2 levels, or at least it can do. And these compensation mechanisms that we keep talking about can mask what's really going on. So you have to measure all these things. The acidity of the blood, the bicarbonate in the blood, the deficit, it was called the base deficit. All of these things have to be in what these people call the big picture. And they're not. No one's talking about them. And we still have this minimizing going on, that none of this is unusual. This is a stable baby. This is so far from a stable baby that is possible to get. And I mean, a good example of that is when Dr. Beery's given evidence. He said that baby G was 97 days old, born at 23 weeks, and she was receiving feeds, including breast milk, via nasogastric tube and bottles, and clearly she was making progress. And with that, her oxygen requirements were coming down. And so we're given a clear picture here. And the court hears baby G was quite stable at this point. Now, this is a baby that's been transferred back to Arrow Park twice. She's had all of these blood infusions, multiple doses of antibiotics, and she was only 585 grams when she was born. So to use the word normal in the context of a baby like that is unwise. And he talks about her weight. So he said, baby G was still a little underweight. Her target weight by this stage at 1.98 kilos. So in 100 days, the baby has put on 1.4 kilos in weight. But if a baby was born at 36 weeks, which is what the baby is now, what would we expect the weight to be? Well, roughly 2.5 to 3 kilos. So you could argue that the baby is substantially under the target weight. And that just reflects the feeding difficulties, hypermetabolism, the use of energy in the preterm baby. And then he talks about the Gaviscon medication, which, has to be used with caution. They were probably using ranitidine as well. And I don't know, there's an increased mortality rate with that. I mean, again, that's something that the jury should have been told about. There's no question in my mind that this baby should have been in a tertiary unit all along. They did not have the personnel or the skill set to deal with ventilation in this baby at all. And failure of ventilation is such a common problem in this unit. We have Dr. Gray making a very strange comment in my opinion, where he says that the baby had compensated metabolic acidosis, and then he says that was an error on his part given the pH reading from a long night. So because he's up awake at night, he doesn't know that a pH reading is either acidic or not acidic. And I just find all these things stunning because they're just so basic. And then the usual, they're describing a baby in distress vomiting. The baby also has green diarrhea. The baby has obviously got gastroenteritis. There's so many things going on with this baby. And then when we get to Ben Myers, this 100 mils of aspiration, Myers asked Bernie what were the contents of the 100 mils. And he says something weird. He says the only other possibility, if it is not stomach contents, is if it's blood. And I certainly don't recall 100 mils of blood. But that's a ridiculous comment. No one has mentioned blood yet, except Dr. Berry. He said it would be recorded as fluid. He says the process of aspirating from an NG tube, if it's just air, then that would be not significant and not recorded. Mr. Myers refers to Dr. Ventus' recollection to the court that the 100 mils aspirate could have been air, although she was not 100% sure. And if it was fluid, she would have recorded that. But we know what the records are like in this hospital. And Myers goes on to say that 100 mils aspiration is not documented in Dr. Berry's note. Now, Dr. Berry says that if you aspirate air, you wouldn't note it. But you would certainly note an aspiration of 100 mils of air. And his excuse is that he was concentrating on baby G's care, and it would have been easier if knowing what was to come to have recorded this on his notes. So this is the retrospective scope that we use in medicine all the time. If only I had known, I would have done this. No, it should have been done as part of routine note-taking while you're actually working with the patients. It's a pain in the butt, but you have to do it. And a lot of people have systems for doing it. I use the SOAP system, subject-object assessment plan, so you break it into 4 little parts and it makes it easier to fit it all out. And then we have Dr. Harkness again. Mr. Myers, for Letby's defence, asked Dr. Harkness if he agrees that a sudden deterioration for BBG is not uncommon. And then the answer is absolutely stunning. Dr. Harkness says it is very rare in a stable term baby. We're not talking about a stable term baby. And then Mr. Myers refers to Dr. Harkness' statement to police in 2018, in which he said for September 7, for this night, BBG had a deterioration which is not uncommon. And of course it isn't uncommon. Dr. Harkness says in his years of subsequent experience, he has seen considerably fewer sudden collapses. At the time of his statement in 2018, he had 7 years' experience. He says, as a point of generalization, it was not uncommon, but in term babies, it was uncommon. Now he has had further years of experience and context. But we're still not talking about term babies. So why is he talking about term babies, and why is Ben Myers allowing him to improvise about issues that are not relevant to the case? And Mr. Myers says in Dr. Harkness' statement to police, the deterioration was no surprise to him. Dr. Harkness says with further years, he has seen less and less and would no longer hold that view. So he would no longer hold the view that a baby who was born 535 gram weight, that had gone through 10 weeks of hospitalization, so many complications that a bronchopulmonary dysplasia, that they can't even get the ventilator to work right on, that he has come to the view that that would be uncommon now, that a baby like that would have a sudden deterioration. And then we get to the very interesting part. Dr. Harkness, again given evidence, tells the court that on the day shift of the 21st of September, he says he cannot remember, aside from using his notes, the events of the day. The court is now showing notes from that day which show that there were 7 attempts to cannulate BBG. 7 attempts. Dr. Harkness' colleague, Dr. John Gibbs, told the court yesterday that in babies such as BBG that require a lot of intensive care, there can be issues with cannulation. Dr. Harkness is recalling the cannulation of BBG around 3:30. He says he was assisting Dr. Gibbs, and he said he was there to pass equipment and keep the baby still. Jobs normally carried out by a nurse. But the guys were obviously so busy with this unit that they had time to do it, helping each other. Asked why a nurse did not assist, he said, I expect nurses were busy, but can't be specific why. Again, listen to that. Nurses on a neonatal unit that is understaffed, and he can't be specific about why they would be busy. Dr. Harkness is now being asked if he remembers whether BBG was hooked up to a monitor. He says she was. He is asked if the sensor from the monitor was moved while attempting cannulation, but of course he cannot remember. He is asked if the sensor would ever be moved, and he said it would occasionally be moved from one limb to the other. He agrees it is important to keep a monitor on and attached. He said it's not safe to turn off a monitor. Asked if he turned off BBG's monitor, he says, I'm not even sure I know how to turn off that particular monitor. At no point would I have turned it off. After the cannulation, Dr. Harkness is asked whether he remembers having any conversation with anyone, and he says he has a vague recollection of speaking to a member of the nursing staff. Ben Myers, defendant, put it to Dr. Harkness that he and Dr. Gibbs left BBG behind the screen, detached from the monitor, and had failed to inform the nursing staff. And Dr. Harkness repeatedly says he can't remember. On the monitor being switched off, he flatly says no. So he can remember that, but he can't remember speaking to a nurse. Ben Myers says, you must know very well, Dr. Harkness, that conversation took place. And Dr. Harkness says, I can't remember. Mr. Myers said, I suggest a detail like that is something you would not forget. And Dr. Harkness says, I disagree. So what's all that about? Well, that's about the cross-examination of Dr. Gibbs as well. And Mr. Myers, again, is questioning Dr. Gibbs. And he asks the medic whether gastroesophageal reflux, which BBG suffered with, could cause projectile vomiting. And he says, possibly. And it possibly can. So there's a reasonable doubt. Mr. Myers is now asking about the monitor. So this is this monitor that Dr. Harkness remembers absolutely that he did not turn off. He asks Dr. Gibbs if the monitor is switched off during the cannulation. He says it shouldn't be. He asks if he can't remember what happened with BBG's monitor on the 21st of September. And Mr. Myers says later, both you and Dr. Harkness spoke to a nurse to apologise for that. Now that happened, didn't it? Dr. Gibbs replied, I'm sorry, but I don't remember that. Mr. Myers said, if you had left a baby unattended without the monitor on, and it's a matter you had to apologise for, you would remember that. And Dr. Gibbs said, I would expect so. And Myers goes on, if you had left a baby like this, it would have concerned you. Yes, said Dr. Gibbs. Mr. Myers said, if it was very busy and you were being overstretched across different parts of the hospital, if you had to leave in a rush, for instance, even though there's two doctors standing doing the same thing, Dr. Gibbs said, that's one reason I might not have had time to speak to a nurse like I should have done, but I can't remember. Mr. Myers said, you apologised that she had been left behind the screen unattended. And Dr. Gibbs said, if that is what the nurse says, then that must have happened. I just don't remember that. Mr. Myers said, and left the monitor switched off. And Dr. Gibbs says, if that is what she said, then presumably that is what happened. So Dr. Gibbs at least has the decency to admit that he did have a conversation with a nurse about this incident that they're tried to blame on Lucy Letby. And then we have an unnamed nurse, and she tells the court, and this, I find this very disturbing. She recalls the events of the 21st of September, and the court was told that BBG was cannulated behind the screen. So this is a screen and this Massimo monitor, a little portable device with all these attachments to it. After the doctors had gone, but BBG was still behind the screen, the nurse told the court that she heard Lucy Letby shouting for help. She said she responded. Miss Letby was using a Neopuff on the infant, and he did not look well at all. So this is BBG did not look well at all, had been left behind this screen after 7 attempts to put a cannula in. She noticed that the monitor screen was black and had been switched off. The nurse said this was not normal practice for the monitor to be switched off. The nurse, however, told the court that she asked to review her original statement to the police last month. So the nurse, she noticed that the monitor screen was black and had been switched off. The nurse said that this was not normal procedure for the monitor to be off. The nurse, however, has told the court that she asked to review her original statement to police last month, as she said she had seen in the prosecution opening that there was a suggestion Miss Letby had turned the monitor off. She said, "I knew that not to be the case." She tells the court on 21st of September, 2 doctors came to her to apologise as they had left the screen in situ and had not switched the monitor back on. And so Brian Myers comes in there and he said that she spoke to detectives last month after reading the opening speeches online, which suggested Lucy Letby had switched off the monitor. From what happened, you knew that was not the case. As far as I'm aware, I believe that was not the case. She said 2 doctors, consultant Dr. Gibbs and registrar Dr. Harkness, approached her the same afternoon to apologise for leaving BBG behind the screen and not turning the monitor back after completing the procedure. Mr. Myers, I suggest Miss Letby was cross that the doctors had left her behind the screen with the monitor off. And the nurse said, "I don't remember that. I remember her being concerned." "Mr. Myers, do you recall?" She said, "This is something to make a formal complaint about." And the witness said, "I don't remember, but I went to my manager to report it myself without anyone suggesting it." So we can have little doubt that this was the type of thing that was going on at the Countess of Chester Hospital. And the police and the prosecution opening statement nakedly attempted to pin this onto Letby. And subsequently, Letby was found guilty of attempted murder of a baby that, in all honesty, had very, very little chance of survival, and certainly, in my opinion, had zero chance of survival in the Countess of Chester Hospital. I'll leave the link to Title Life. Go through it yourself. See how much confusion, how much lack of planning, following up, moving the baby from one place to another. Read about another parent. Read about the parent asking the consultant whether the baby had an infection because there was another baby on the ward with an infection. And why on earth would the baby not have an infection in a filthy, sewer-soaked place like this? It's positively third world environment, third world medicine. So there's so much information on Baby G. They were unable to ventilate her. They didn't consider ventilation perfusion mismatch. They didn't consider the possibility of Gaviscon. And then we had Dowie Evans coming in with his fantastical theory about how all of this happened, feeding intolerances, people not recording things right, no one knowing sometimes where the babies were, let alone what they were feeding them. And we have to, of course, finish up with the cross-examination of Dowie Evans, this man. Ben Myers, for Letby's defence, is now asking Dr. Evans questions about the September 21st incident. He says one of Dr. Evans' earlier reports said there had not been evidence of a life-threatening event for September the 21st. Dr. Evans said he overlooked it when going through 4,000 plus pages of evidence, which had included these nursing notes. So here he's not talking about 4,000 pages of evidence for Baby G. He's talking about 4,000 pages of evidence for all these babies. There would not be 4,000 pages of evidence for one baby. Mr. Myers is now asking about the nursing notes by Nurse Melanie Taylor on September 30th, 2015, which Dr. Evans identified. The note includes Baby G had desaturations with one profound desat apnea and requiring position changed and oxygen this morning. Dr. Evans had recorded the observations required further looking at. So, in other words, we need to go fishing in this normal pool of behaviour for these very vulnerable babies. And Mr. Myers returns to the September 21st incident and says, the projectile vomiting is a cause for concern that Dr. Evans identified. Mr. Myers says the incident does not record the amount of vomiting or how far it travelled. Unlike the September 7th incident, Dr. Evans said it was not a self-resolving incident, and it was significant that BBG vomited twice and stopped breathing. He said it was a serious event, but not as serious as the one on September the 7th. Mr. Myers said the incident was brief. The court is shown a note from Dr. Peter Fielding from September 21st in which the bowels were open and the stools were loose and green. Mr. Myers asked if it is a sign that BBG is in overall poor health. And Evans, of course, loose stools are common in babies. So there you go. Green loose stools in the context of vomiting generally mean gastroenteritis. Dr. Evans said, Mr. Myers asked if there was a more marked history of BBG vomiting upon her return from Arrow Park in September 16, 2015. Dr. Evans said the events of September 7th left her a significantly changed baby and agrees vomiting was more likely. So this is where the profound desaturations and the ill health resulted in more bleeding into the brain. Intraventricular hemorrhaging, it's called in these little babies, and it's devastating for them. BBG was then receiving feeding by tube. Mr. Myers said there were numerous occasions of BBG vomiting from September 16th, and the incident of September 21st followed a pattern. And Dr. Evans says he agrees to the basic arithmetic in that BBG still had 30 mils of milk in the stomach after a 40 ml feed and 2 projectile vomits. Mr. Myers says, we don't know how much milk came up with those vomits. Dr. Evans said the nursing notes are pretty descriptive, and no nurse would describe 2 vomits as 5 mils each, as that would amount to a spoonful each. It had to be more than 40 mils at 9 a.m., which would explain the distended abdomen. The judge asked if there are any other entries of projectile vomiting recorded for BBG in the notes, and Dr. Evans says there's not. So the projectile vomiting, not even recorded right, nobody's measured it, it's all in Dr. Evans' head. And we all know that he has since changed his mind about pumping air into baby's stomach. This man is the most unreliable witness you can imagine. So, last up, Dr. Sandy Bowen. Mr. Johnson takes Dr. Sandy Bowen through her reports in which she said there was no cause for concern in Baby G's condition at the Countess of Chester Hospital before September 7, 2015. None, no cause for concern. Dr. Bowen confirmed Baby G was given 45 mils of milk via nasogastric tube at 2 a.m. on September the 7th. Mr. Johnson refers to the subsequent sequence of events and that Dr. Bowen has recorded what had happened from the medical staff of notes in the medical chart. Dr. Bowen said Baby G, prior to the collapse, was very stable with decreasing oxygen support. So a very stable baby that required oxygen support. And she was managing very well on that. From a respiratory point of view, all was well. She was requiring oxygen support, but all was well. BBG was tolerating 3 hourly feeds, and she was progressing very well, even though her weight has not got anywhere near where you would have hoped it would have got. The observation charts prior to 2 a.m. feed were completely normal. The episode of projectile vomiting was concerning, as Dr. Bowen said she had not seen babies, particularly those weighing 2 kilograms, doing that. She found that extraordinary. So here we go again. Because she hasn't seen something before, it's extraordinary. Well, it's in the literature. Why don't you look there? Dr. Bowen said the milk must have come from somewhere, and the vomit has to go over the side of a deep-sided cot onto the floor and the nearby chair. A considerable force has to be generated inside the abdomen. She said there must have been much more than 45 mils of milk inside the stomach, and she has no idea. This is a story. Mr. Johnson asked if there was an innocent explanation which would have explained the projectile vomit. Well, I've just given you one innocent explanation: overpressurized stomach, Gavus Gombazor, or just it happened. Dr. Bowen said no, as the stomach was empty with a pH reading of 4, if there was milk in the stomach, it would have neutralized the stomach and the pH reading would have been higher. What is she talking about? So milk itself, breast milk itself, is acidic. Even though it's mildly acidic, it's not going to neutralize another acid. And one acid will not neutralize another acid. But she's leaving out the bit that once the baby feeds, the stimulus is to produce more stomach acid. So after we eat, the pH of the stomach falls. In other words, we make a lot more acid. So this is just scientific bollocks. I think the stomach was empty, so she thinks the stomach was empty, and she was given excess milk and possibly air, which distended the stomach. Don't forget, this baby's on positive pressure ventilation as well. So she thinks all this happened. And Dr. Bowen is asked by police about Lucy Letby saying babies take on a lot of air when vomiting. Dr. Bowen was asked if that was correct or not. Dr. Bowen tells the court that's not correct. Babies do not take on air when. Babies can take on air before they vomit, after they vomit, and if they don't vomit. It's called aerophagia. If a baby vomits, becomes agitated, breathes fast, it's going to swallow more air. Do you know how many myths there are in medicine about why things happen? Millions. So this is just a spiteful comment that has no real value in this trial, but sets out to make Letby look like a manipulative liar. Ben Myers, defending, is now questioning Dr. Bowen and he is asking the court back over Baby G's medical notes from June 2015. Dr. Bowen agrees at this time the premature girl was as sick as you could possibly get. Mr. Myers is looking at notes that said she had a discoloured abdomen. Dr. Bowen says at that stage the girl would have weighed just 500 grams and there would be no subcutaneous fat. So we could see blood vessels, hence discoloration. So discoloration in the abdomen, normal when you want it to be, not normal when you don't want it to be. We're continuing to view notes on Baby G for the past few weeks after birth to show that she was on steroids as she was having trouble with ventilation. So steroids as well. Bleeding noticed at one point was put down to a probable pulmonary hemorrhage. So that's bleeding into the lung. Dr. Bowen notes that Baby G had a low platelet count, which could explain the bleeding. She says, certainly in a baby this fragile, pulmonary hemorrhage could be lethal. States if it had been such a hemorrhage, it was very mild. Mr. Myers is asking the court to go through the notes at the end of July 2015, which showed a significant desaturation before Baby G was due to travel from Arrow Park. Dr. Bowen agrees that the infant was not well at that stage. She was still very young, still very vulnerable, and prone to all sorts of complications due to her prematurity. Mr. Myers is making the point that as an expert witness, Dr. Bowen is allowed to hear all the evidence as presented to the court. She rejects suggestions that her conclusions have come from dialogue with Dr. Evans, the other medical expert in this case. Now she's being called to give evidence again. Baby G, we're going to get a wonderful picture of Baby G. And Dr. Bowen said Baby G had been tolerating well up until the 21st and had 2 large projectile vomits after being given a 9 a.m. feed while asleep. Nicholas Johnson KC says Dr. Bowen refers to 6 a.m. 45 mils of milk, and Lucy Letby records a 40 ml nasogastric tube feed for milk at 9 a.m. Following the 2 large projectile vomits, 30 mils of milk was aspirated from BBG. Dr. Bowen said the events just didn't add up from the 40 ml feed. She said the 2 projectile vomits would have been more than a mouthful of milk of 5 to 10 mils each, and basic arithmetic meant that more than 40 mils of milk would have been administered at 9 a.m. Ben Myers is now asking Bowen questions. He says, we don't know how much milk there was in Baby G's stomach prior to the 9 a.m. feed. Dr. Bowen says that is the case. He had been tolerating feeds well. So we don't know, but she's been tolerating feeds well. Dr. Bowen said there is a difference between a posset, which is a small vomit, a medium vomit, and a large vomit. My God, the intellect. Mr. Myers says, we don't have the basic figures, do we? Dr. Bowen says, we don't. But there are descriptions which nurses use to outline the quantities of vomit. So, we're storytelling again. Mr. Myers says the incident was not on the same level of the September 7th incident. Dr. Bowen disagrees. Of course she does, saying the incident was still serious. She agrees it was not on the same scale, as the events were almost identical, even if the repercussions of what followed were not as serious as that on September the 7th. Myers says the incident is not on the same level, and she says, no, it is on the same level, even if the repercussions were not as serious. That's what we call outcomes. So the outcomes were less for the 21st incident than they were for the 7th incident. So they're not on the same level. Dr. Bowen agrees that vomiting became much more of a feature for Baby G upon her return from Morrow Park Hospital. I wonder why that was, but says there was only records of projectile vomiting on the 7th and the 21st of September. Mr. Myers says from October the 3rd to the 8th, 2015, Dr. Bowen had recorded Baby G had 1 to 2 vomits each day, varying from small to large, and some after a nappy change. A nursing note of October 8th shown to the court records 2 large vomits for Baby G, and the feeding regime was changed as a result. On October 9th, another nurse notes, tolerated 3/8, 3 feeds 8 hours apart, feeds well, 2 large digested milky vomits. This is followed by another large vomit on October the 9th. Dr. Bowen says the difference with these vomits is that they are not projectile vomiting and did not cause Baby G to be medically compromised. No, she can just keep on vomiting away and it will never cause her to be medically compromised. Mr. Myers refers to an incident of projectile and quite large in size vomit for Baby G on October 15th, 2015. Dr. Bowen says she has looked through many documents and charts in this case and may have overlooked the one incident of projectile vomiting. So she may have overlooked the one incident that proves that everything she said before now is complete fantasy. Mr. Myers refers to the other large vomits on October 17th and October 22nd, the latter with wind following feed. He refers to BBG's father's statement in which he said since September 7th, he had seen BBG projectile vomit and covered the cot. Dr. Bowen says, with another attack, of course, on the parent, with the greatest of respect, parents can refer to projectile vomit when they mean vomiting, just like experts. And then finally we get to Professor Arthur Owens, who's the guy who reads CT scans, even though there aren't any, and X-rays and other images in the case. Dr. Arthur is taking the court through radiographs taken at Arrow Park Hospital and the Countess of Chester Hospital. So there we have the old radiographs, no CT scans. Dr. Arthur said there isn't anything specific to suggest BBC had suffered from sepsis, neck, or any other infection. He said there was nothing on the X-rays that would provide a diagnosis for BBG's condition. So a very useful contribution. But Professor Owens knows that radiographs of the abdomen are not very good at revealing serious conditions, because in the case of BBA, he actually told us, he wrote a paper about that. So it's worth noting. We'll leave it there. I can't find a word for what I think about this. Inventing quantities of milk. I just don't know what to make of this as evidence from so-called expert witnesses. It's beyond me. But we'll finish with BBG now and wish her well for her future. We'll see you in the next episode when we start with the cases of BBH and BBI, which are both attempted murders. And I'm sure it'll just be the same old story. But anyway, bye.